Good morning, doctors. How are you doing? Today, we're gonna read a new guidelines from the Neonatal Guidelines book, 2024, which is the recent guidelines for neonatal medicine, UK guidelines. Okay. Um, uh, I have chosen this guideline, which is related to neonatal seizures, which is very important and so crucial in your work, in your workplace, on every single day. Also in your exams, whether you are preparing to appear in MRCBCH clinical exams or RCBI Ireland exams as well. So let's start figuring out, okay? Neonatal seizures, as we all know that it's manifestations of neurological dysfunction. Seizures occur in 1 to 3% of term newborn babies, and in a greater proportion of preterm babies, they can be subtle, clonic, myoclonic, tonic. It could be anything, okay? So how you can recognize a child is seizing in your unit, and how you can assess him or assess her. Okay, so we have a couple of physical signs. We have to spot it. In addition to obvious convulsive movements you can see in the baby, you have to look for also check his eyes for staring, blinking, any horizontal deviation, his mouth for mouthing, chewing, sucking, tongue thrusting, lip smacking, for his limbs, boxing, cycling, pedaling. There are also autonomic manifestations, which is apnea, tachycardia, unsettled blood pressure, focal, one extremity could be involved, or multifocal, several body parts involved as well. Perform a detailed physical examination and neurological assessment as well. So you have to do a complete physical examination and you focus on the CNS examination in particular. So what's your differential in here? How you gonna think? What's your plan? What's your differential at this point? So when you see a child like this, you want to think of, it could be jitterness, just simple jitterness, or it could be a benign sleep myoclonus, or it could be other differential diagnosis, which is maybe more risky and dangerous. You're gonna think out of the box, okay? So if it was a Saturnus, so this is kind of tremulous, jerky, stimulus provoked, and seizing with bass affliction. When you touch the baby, the Saturnus is gonna stop. Benign sleep myoclonus, which is focal or generalized myoclonic limb jerks that do not involve the face. So the face is spared in the benign sleep myoclonus, occurring when baby is going to or waking up from sleep, whether he is going to sleep or during sleep or he just woke up from his nap. So EEG is going to be normal, resolved by age 4 to 6 months. You're going to assure the baby, you're going to assure the parents when you are like pretty confident to make this diagnosis that this baby gonna be okay when he reach the age between 4 to 6 months. Differentiation between jitterness and seizure. How I can know this is not a seizure? It's not actual seizure. It's just a jitterness. So here's we have the timetable for that. So in jitterness, there is a stimulus provoked, but in seizure, it's not provoked. So jitterness can be provoked by cold, by metabolic disturbance in his body, but in seizures, it's not provoked. It just comes of once in a blue moon. Is like it comes from no reason, for no reason. Okay, so the other differentiation that jitterness is predominant movement, and it's rapid oscillatory tremor. Okay, it's like he's shivering. Seizure is whether it's clonic or tonic, that's contraction relaxation, or completely tonic. movements. It's completely rigid, like complete rigid body in front of you. Okay, so endogenous movement cease when limb is held, yes. While seizure, no. Seizures will never stop when you held or hold any limbs. Okay. The conscious state, the baby would be awake or asleep in gentleness, but in seizure he gonna be altered, like his conscious level is altered. Okay. Regarding his eye deviation, so in Jeternes there is no eye deviation. In seizures, yes, there is eye deviation. So we have these comparisons, very nice and clear. So it's regarding stimulus provocation, whether the movement is predominant or not. Movement sees when limb is held or conscious status and eye deviation. Okay, so now you are like putting your differential diagnosis list, and now you are thinking about what investigation I have to ask for. So you have to be concise, so don't waste your resources in your workplace, and you have to think wisely. Okay, so what investigations you're going to ask for? We have the first line and second line investigations. First line, at this point you have to ask for blood glucose. It could be hypoglycemia, serum electrolyte, including calcium and magnesium. So it could be metabolic disturbance, hypocalcemia, or hypomagnesemia. You're going to ask for full blood count and coagulation profile if stroke suspected, thrombophilia screen. Blood gases as well, blood culture, CRB, liver function test, serum ammonia and ammonia acids, urine toxicology, amino acids, organic acids, lumbar puncture is crucial, CSF, microscopy and culture, bacteria and viral PCR for herpes simplex, including enteroviruses. Discuss the CSF sample for future metabolic testing, for glycine, lactate. So just think about metabolic stuff, with your consultant. Cranial ultrasound scan to exclude intracranial hemorrhages is also could be in the form of seizures. EEG to identify electrographic seizures and to monitor response to therapy. Consider cerebral function monitoring. Okay. So that's the first line investigations. So just straightforward, it's basic investigations. Now the second line investigations, congenital infection screen. You have to think about TORCH. He is a neonate, so you have to think about TORCH screen. MRI scan, screen for maternal substance abuse. Serum acyl carnitine, biotinidase, uric acid, the metabolic stuff, total and free homocysteine, could be homocystinuria. Trial of pyridoxine treatment, preferably during EEG monitoring, may be diagnostic as well as therapeutic, which is vitamin B6 pyridoxine. If further advice required, contact metabolic team. Okay, so think about metabolic stuff and the disturbances of the minerals. Now, what's the treatment? How I have to interfere at this moment? How I can help this baby? So treatment. Number one, you have to think about ABC, ABC, ABC. It's an emergency, it's an acute state, it's an seizure, he's seizing. So you have to ensure ABC, airway, breathing, circulation. Treat underlying causes. If there's hypoglycemia, electrolyte abnormalities, any infections, hypoglycemia, you have to you give glucose 10%, 2.5 to 5 ml per kg bolus, followed by maintenance infusion. Wherever possible, obtain hypoglycemia screen before administration of glucose bolus. Okay. Hypocalcemia, total calcium less than 1.7 millimole per liter, or ionized calcium less than 0.64 millimole per liter. So in this situation, you have to give calcium gluconate 10%, half ml per kg IV over 5 to 10 minutes with ECG monitoring, because there's a risk of a tissue damage if there's extravasation for this medication. Okay, there is hypocalcemia guidelines. It's a separate topic by itself. We're gonna read it next time. Hypomagnesemia, when it's less than 1 millimole per liter. So in here you give magnesium sulfate 100 milligram per kg IV or deep IM, also used for refractory hypocalcemic seizures. So in case of hypocalcemia, you are not giving only calcium gluconate. You have to give hand by hand, side by side, magnesium sulfate, because it could be like hypocalcemia and hypomagnesemia at the same time, okay? Pyridoxine, 50 to 100 milligram IV can be given to babies unresponsive to conventional anticonvulsants or seek neurological opinions. So think about pyridoxine. You give it to babies do not respond to the anticonvulsant medications that you have tried, okay? Initiation of anticonvulsants for immediate management flow chart. So in here, you have to start anticonvulsant drugs, but there's a criteria for that. If the seizures prolonged more than 2 to 3 minutes, if the seizure frequent more than 2 to 3 seizures per hour, associated with cardiorespiratory compromise, frequent apneas, and bradycardia requiring intervention. So there's criteria for starting anti-convulsant drugs. If it's prolonged more than 3 minutes, if it's frequent, like more than 3 times per hour, if there's cardiopulmonary compromisation, the baby starting to be apneic and bradycardic. So in this situation, you have to think about anticonvulsant medications. So how are you going to administer these medications? IV to achieve rapid onset of action and predictable blood levels to maximize doses before introducing the second drug. If no IV access at all and glucose and electrolytes abnormals excluded, consideration can be given to buccal, intranasal, midazolam. So in here, there's no IV access. You have to think about other routes, like you can give it by mouth, buccal, or intranasal midazolam. Maintenance and duration of the treatment. Keep duration of treatment as short as possible. This will depend on diagnosis and likelihood of recurrence. May not require maintenance therapy after loading dose. Some babies respond to the loading dose, okay? And some of them still keep needing, they do need a maintenance dose after that, okay? If maintenance therapy is required, monitor serum level. So you have to keep an eye on the drug level, okay? Develop emergency seizures management plan, including, if required, plan for buccal intranasal midazolam. Okay, but when you're going to stop the treatment, you have to consider seizures have ceased and neurological examination is normal. You have to completely, your guide in here is the CNS examination. Once your neurological examination seems normal for you, you are satisfied, so you can go and stop your treatment, and you have to consult your senior with you in this, okay? Abnormal neurological examination with normal EEG. So in your examination, you got some abnormal neurological signs, still sinus examination, not normal, but you have normal EEG. You can think about stopping the treatment. Okay, we have here in this page, we have the drug-wise anticonvulsant medications that you need to go through. We have the phenobarbital, which is used in babies, newborn babies. The second is phenytoin, midazolam, clonazepam, lidocaine, levetiracetam, which is introduced recently to the guidelines. So phenobarb, we all know the doses. Okay, you can go through these doses. Like, we know the loading dose is 20 milligram per kg IV. And the maintenance dose is 2.5 to 5 milligram per kg IV, okay? Phenytoin as well, 20 milligram per kg IV. In here, you have to monitor the cardiac rate and rhythm and blood pressure for hypotension. This is a side effect of phenytoin. It may cause hypotension, drop in the blood pressure. The maintenance dose as well, 2.5 to 5 milligram per kg IV or orally 12 hourly. Measure the trough level 48 hours after IV loading dose. Okay, midazolam if no response to above drugs. So you have tried phenobarb, you have tried phenytoin, no response at all. So you have to shift to the midazolam, which is 200 microgram per kg IV over 5 minutes, followed by continuous infusion, reconstitution and dilution. So this is talking about only how to prepare the medication. So what's the side effects of midazolam? It may cause significant respiratory depression and hypotension if injected rapidly or used in conjunction with narcotics. If no IV access at all, glucose and electrolyte abnormalities excluded. Yoga 300 microgram per kg intranasal or buccal. You can repeat the midazolam dose once. You have to wait 10 minutes before repeating the dose. Okay, make sure that the heart and respiratory system working well, and they are stable. Okay, clonazepam if midazolam not working or not available at all in your workplace, you shift to clonazepam, which is 100 microgram per kg IV over 10 minutes. You can repeat the dose after 24 hours. Okay, so if you give clonazepam with phenytoin in here, this will cause reduction in the half-life of clonazepam. So you have to put this point in your mind. Lidocaine, if all above medications we have mentioned didn't work, you will think about lidocaine, which is anesthetic, 2 milligram per kg IV over 10 minutes, then commence infusion. Okay, they explained everything here. Exercise caution with phenytoin as concurrent IV infusion of both these drugs has cardiac depressant action. Refer to the neonatal doses in preterm babies. So be careful if you are giving phenytoin and lidocaine together. This will cause cardiac depression or cardiac arrest. Okay, levetiracetam if not responding in any order, so levetiracetam is the last option. Everything you have tried, it didn't work, so you have to think about levetiracetam. Loading dose 20 milligram per kg IV infusion over 15 minutes, can be repeated if seizures persist. 10 to 15 milligram per kg 12 hourly. This is the maintenance dose. Have maintenance dose in infants with severe renal impairment, or if there's any renal involvement or renal affection. So you're going to calculate the half of this dose and give it to the infants with renal impairment. Okay. You have done all this, so let's go through this again just to memorize. So you have the first option, phenobarb, then phenytoin, midazolam, clonazepam, lidocaine, and the last option, levetiracetam. Okay, now discharge and follow up. When are you going, or when are you deciding to discharge this baby and you are satisfying with his situation and he's stable? You are thinking about discharge now. Ensure parents are provided with appropriate discharge documentation, seizure emergency management plan. So what they gonna do if their baby sees again at home? Copy of discharge summary, including types of seizures, medications, anticonvulsant administered. All this you have to provide parents with all these informations. Okay. Then you have the follow-up point of view. Follow-up will depend on cause of seizures and response to treatment. Consider specialist follow-up for babies discharged on anticonvulsant drugs. So if the baby did not have any anticonvulsant medications while he was admitted, in a hospital. So there was this no need for follow-up by a specialist. But if the baby taking anticonvulsant medications, he need follow-up by a specialist. Okay. And here we have further informations for this is like a leaflet NHS seizure newborns PDF. You can click on it. You can read it in your spare time. The last page of this guideline, which is seizures in the neonates, we have the flow chart, immediate management. So all this like summarizing what we have read so far in this guideline, you can go through this diagram quickly just to memorize, and like it's like mind map for yourself. Okay, it's nice for like to memorize on the night for your exam. Okay, this is the end of our guideline today, doctors. Thank you for watching, and please support the channel by your likes and your comments. And I will keep uploading more videos in the next couple of weeks. Thank you for watching, and best of luck for your exams.